We initially thought that the challenges were going to be financial predominantly. I will say that the successes of investigators, patients, societies, and the companies to get the CMS to put in a DRG that was able to support this therapy was successful. And October of 2020, that new DRG went into place and really does cover the cost. So patients across the country, whether they have Medicare or private insurance, should be able to get access to these therapies, and that the costs are no longer being thought to be prohibitive or outside of the benefits that the patients are obtaining. So what is the limitation now? I think it's really getting the word out to the patients, to their families, and to the community docs that these therapies are really valuable to the patients, that the durability of the responses are, again, 40% or more at 4 years, as shown in the ZUMA-1 study. And we expect in the real world, we'll have a less heavily treated patient population with a better durability of response. We'll have to prove that. I think the limitations at this point are really getting the therapy to the patients, getting them into the clinics early before they have large tumor burden and when they can still have the maximum benefit from the therapy. So it's a lot of education. And I think you're helping me right now by getting the word out to patients, families, and docs. So here's the challenge to the industry and to the investigators. We've had an amazing start into managing lymphoma, now expanding into follicular lymphoma, mantle cell. And we do anticipate an indication for adult acute lymphoblastic leukemia this year. We have an indication in multiple myeloma. The success and the benefits of the therapies are evident, but they're not perfect. And so what I would say the challenge to the community is to bring forward what we've learned from our 5-year experience in CAR T thus far and really get the second generation of the cells. And where are the opportunities? The opportunities are multi-targeted antigen CAR T cells. That's been the focus of my group at Stanford. Also a tremendous opportunity to use allogeneic CAR T cells, those cells that are already prepared, that the patient's cells don't have to be harvested, manufactured, and go through that sometimes 1 month ordeal because patients have chemo-refractory disease and they need therapy tomorrow. So if we could have therapies that are already to go, but offering the same advantage of cellular therapy, that would be a huge advantage. And I think the third final issue is there must be a preferred T cell phenotype that makes the best CAR T cell effector. And many of us are trying to figure out which of the phenotypes, which of the T cells need to be transduced and made into the CAR to make the most effective lymphoma, myeloma, or leukemia killing cell. So those three things are what keep my group busy.